One medicine is in the business of saving lives, and the other business is improving the quality of life.
You're right. People don't talk about sexual health. We talk about muscle health. We talk about exercise.
40% of men suffer from ED at 40 years of age. 50% at 50, 60% at 60, 70 at 70, 100 at 100. You live long enough, ED is going to affect most men. 43% of women over the age of 50 will have some degree of female sexual dysfunction. I don't want to take a drug. I don't take a pill. What can I do naturally to improve my sexual function? The more severe ED you had, the greater the improvements you would see in sexual function just by exercise alone. So I can't stress the importance of diet, exercise, sleep, and stress reduction. I call those the 4 pillars. Realize that healthier people tend to be more sexually active.
Dr. Mohed Khera, thank you so much for coming on the show. I am honored to be able to sit with you. You are arguably the world-leading expert on testosterone and andrology. Truly a pleasure.
Great to have you. Great to have me. Thank you.
Tell me about what inspired you to be doing what you're doing. And just to lay the foundation for people, you have published over 200 scientific papers, if not more. You are really leading the charge and transforming the way that we think about sexual medicine, the way we think about andrology. You are an absolute maverick. How did you get here?
First of all, you're too kind. But the reality is this. I look at 2 types of medicine. One medicine is in the business of saving lives, and the other business is improving the quality of life. So what I do is improving the quality of life. Patients come to me, many are depressed, they're anxious. Sexual dysfunction is not commonly discussed, but many, many people suffer from this condition, and they don't want to talk about it. So what we do is we try to improve the quality of life.
And you're right. People don't talk about sexual health. We talk about muscle health. We talk about exercise. We talk about cholesterol. Do you think that the reason that we don't is because people are embarrassed, or it's a stigma, or is it the thing that really impacts them so much that maybe there's shame around it?
There's a huge stigma around it, and many patients are very embarrassed to discuss this. I want to give you just an example. There was a survey that came out 2 years ago, and it was given to over 1,500 patients. And what they found in the survey was that 69% of patients said they don't even know where to get sexual medicine health care. They have no idea. What was really surprising about this is that roughly 51% of those patients ever discuss this with their provider, and less than half of the patients ever discuss it with their partner. So think about this. They're embarrassed, right?
Yeah.
So I call this suffering in silence. They don't want to discuss it. Majority of patients who suffer from sexual dysfunction don't talk about it, and it's a major concern.
When I think about overall health and wellness, I think it's important to define sexual medicine. What is sexual medicine? What is andrology? We're going to talk all about hormone replacement. We're definitely going to talk about hormones. Everybody wants to know about testosterone for men and women. But what are some of the definitions that we can start off with of understanding?
There's so many components of sexual dysfunction. I'll give you some examples. First, you can think of erectile dysfunction, which is the most common. We can think of low libido. Don't forget that we have sexual dysfunction in men and women. It's different, right? So many men and women can suffer from HSDD, hypoactive sexual desire disorder. Peyronie's disease, which is an abnormal curvature of the penis when the penis is erect. 9% of all men suffer from Peyronie's disease.
That's a lot.
Pretty significant.
Yeah.
In fact, if you look at the statistics for erectile dysfunction, 40% of men suffer from ED at 40 years of age. 50% at 50, 60% at 60, 70 at 70, 100 at 100. You live long enough, ED is going to affect most men. So that it's a very, very prominent, common condition, but we don't talk about it. Other conditions, premature ejaculation. It affects 30% of men. The 30% of men suffer from that condition, right? So low testosterone. We know that roughly 52% of men over the age of 40 will have low testosterone, and many of these men will suffer from the signs and symptoms.
52%. Let's pause.
Yes.
52% of men will suffer from low testosterone. 40% of men by 40 years old have some kind of erectile dysfunction.
Absolutely. Now, let's talk about that low testosterone for a second. Just because you have low testosterone doesn't mean you're a candidate for therapy unless you have symptoms. So you have to have signs and symptoms and a low testosterone level. Now, if you look at how many men have signs and symptoms and a low testosterone level, that number drops to about 8%, almost up to 10% over the age of 50. That's still a significant number of patients who suffer from this condition. We don't talk about it.
And when you think about for women, what are the numbers for women?
43% of women over the age of 50 will have some degree of female sexual dysfunction. Now, when you talk about female sexual dysfunction, there are 4 components. So let's talk about them. Low libido, arousal, which means blood flow to the genitalia or the breasts, orgasmic disorder, and pain. So 43% of women, that's significant. Now, the key thing about female sexual dysfunction is that she has to have one of those components and she has to be bothered by it. Let's say a woman comes in and she says, I have low libido, but I don't really care. Well, then she doesn't have FSD, right? So she has to have signs and symptoms, and she has to be bothered by the condition. 43% of women. Now realize that of the 43% of women that suffer from this condition, only 9% of those women seek therapy. And in those cases, the remainder just suffer in silence.
And how long have you been in practice?
So I've been in practice now for 17 years.
17 years. And you did something before.
Yes. So before I was an analyst, I did my MBA. I was a healthcare analyst for 2 years in Boston. And I didn't like it. I just didn't like it. I didn't like it. I just felt like, every day it was just a presentation and meetings, and I just felt like I just didn't feel like I was making a difference. So I went back and took some more prerequisite classes in medical school, for med school. My wife was in Boston at the time, and she was going to medical school. So I loved what she was doing and applied and came back to the University of Texas and finished my medical school.
This episode is brought to you by Maui Nui Venison. Maui Nui Venison is one of the best, finest tasting red meats on the planet. Maui Nui Venison is a mission-based food company. We love it. My kids love it, especially their little jerkies. By the way, not only do they use them as swords, but as snacks. And listen, that is a hard sell. Getting your kids to eat healthy, Maui Nui Venison does an amazing job. It is high in protein and low in fat, which again, depending on your macros, is amazing, and high in B vitamins, iron, all of the micronutrients, vitamins and minerals that we need. Not only that, you don't have to go anywhere. It will come straight to your door. That's right. Go to MauiNuiVenison.com. For your first order, you'll get 20% off. Amazing. Who doesn't like to save money? And the product is extraordinary. Go to MauiNuiVenison.com/Lyon, roar, not that kind, Lyon, and try it. You will love it. Back to the episode. How did you decide on urology? For those listening, urology is a combination of surgery. Really, you can do anything. I think urology is one of the most important specialties that we have. It's somewhat of a gentleman's or gentlewoman's, however you want to say it, specialty. You do surgical procedures and you take care of lifestyle.
Yeah. So hands down, there is not a better specialty than urology, not one. Urology not only is taking care of patients medically, but when they need surgery, you are also the surgeon. It's one of those very few specialties where you get to do both. So I don't send out surgical cases. I do my own surgical cases. And remember, we're in the business, when you look at urology, the best specialty in urology is sexual medicine, by far.
I know.
In terms of improving the quality of life, and many patients don't know where to seek care, but hands down, by far the best specialty.
And you're not biased.
No, I'm not biased, but
it's incredible. And how would one define andrology?
So it's really the study of testosterone and androgens and the effect those have on the body. So, andrology is a subset of sexual medicine. So sexual medicine could be erectile dysfunction, Peyronie's disease, premature ejaculation. There are many conditions. Andrology is a subset because it affects many of those conditions, but mainly the study of testosterone and how it affects the body.
That's fascinating. And have you seen the landscape change? Because we're hearing a lot more about hormone replacement, testosterone, not so much sexual health. But over the last 17 years, have you seen changes in the field and
Absolutely.
advancements.
There's been so much more discussion. So we're much more open to talk about sexual dysfunction like we're doing today. I didn't see that 15 years ago. And the reality is that patients now demand it, right? They're saying, look, I want a better quality of life, right? I want to have a better quality of life, and sexual dysfunction now has become more and more important. Now, we do see a lot of clinics that have popped up that are offering therapy, and that's fine. That's just a testament to the fact that more people are demanding care. But patients now want to have a better quality of life, and sexual medicine is one way to improve their quality of life.
Do you feel that there are still a lot of misconceptions out there about, for example, you've really led the way, this idea of, for many people, they believe that testosterone causes, for example, prostate cancer. People also believe that testosterone is dangerous and can cause cardiovascular disease. What I think is fascinating about your work, and you've done work in multiple domains in sexual medicine and andrology, is you've really challenged some of these beliefs. And I'd love for you to speak on that, because medicine is interesting. We get an idea in our head. I say we, the collective medical societies, and then we execute on that without challenging the underlying science, just like the Women's Health Initiative.
Yeah. Yeah, so there's so much to talk about testosterone, and I think let's talk about prostate cancer. In 1941, Huggins and Hodges said that testosterone actually can increase the risk of prostate cancer. And from that date, from 41, for decades, we believed that testosterone increases the risk of prostate cancer. It wasn't until the AUA guidelines came out in 2018 and said, look, testosterone does not increase the risk of prostate cancer, and that was a strong recommendation. So that's important. So we used to believe it for many years. But the paradigm has completely shifted. If you look now at how we use testosterone, there's now data to suggest that if you can give men testosterone and normalize their testosterone, the risk of prostate cancer may be reduced. In fact, men with lower testosterone levels may have a higher risk for prostate cancer. And there's a wonderful study that came out in 2015 out of Hopkins. Do you know how they treat men with metastatic prostate cancer? They give them high doses of testosterone. This is called BAT, bipolar androgen therapy. And what this high dose of testosterone does, it tricks the prostate from becoming insensitive to sensitive, right? So who would have thought decades ago, I'm going to use high doses of testosterone to treat men with metastatic prostate cancer? But it's very clever. As you increase the dose of testosterone and then bring it back down, what you do is you trick the cancer from becoming insensitive to sensitive. And in one of the studies, you see a 50% reduction in the PSA, 50% reduction in metastatic disease. Unheard of to give men high doses of testosterone with metastatic disease. So the paradigm is shifting completely, and how we think about testosterone and its true effects on prostate cancer. Now, let's be fair. We don't have a large randomized placebo-controlled trial saying yet that testosterone is safe in men with prostate cancer, and that's why the guidelines say, we don't. The risk-benefit ratio has not been established. But it's interesting. Treating men with metastatic prostate cancer with testosterone, amazing.
It changes everything.
Yeah.
In your practice, what are some of the most frequent disease processes, complaints that you encounter in both men and women?
I see so many men and women for sexual dysfunction. So when I see men for sexual dysfunction, I see a lot of men for erectile dysfunction, right? So that's a very common condition
and
as
how
well.
would that be defined?
So it's inability to obtain or maintain an erection, right? So inability to obtain or maintain. That's the easiest way to define it. Some men can obtain the erection, they can't maintain the erection, right? And the statistics are very similar to when I told you about low testosterone. 50% of men over the age of 50, 60% over 60, same numbers. It's amazing how many men suffer from this condition and we don't talk about it, right? So erectile dysfunction is a very common condition. Premature ejaculation, right? So, 30% of men will suffer from some degree of premature ejaculation, which can be very bothersome to the relationship. The average man will ejaculate within 7 minutes. Premature ejaculation, most men will ejaculate less than 1 minute, right? And there's a discrepancy, so it's very important to realize that men and women, premature ejaculation can have a big impact on their relationship. How about Peyronie's disease? 7 to 9% of men suffer from this.
And what is the cause of that?
So I believe that so as men get older and as they start developing a mild erectile dysfunction, they start increasing the risk of having a buckling incident during sex. So let me give you an example. If a man has a 100% rigid penis, he's fine. He's not going to injure himself. If he has a 50% rigid penis, he's not going to be able to penetrate in the first place. But he's in trouble when he has a 90%, 80%, 70% rigid penis, because what's going to happen is he's going to penetrate and he's going to buckle and injure the penile tissue. And when he injures the penile tissue, what happens is you develop a scar. Now, the best way I want you to think about this is if you have a balloon, and if I put a piece of duct tape on that balloon and I blow that balloon up, what do you think is going to happen? It's going to curve in the direction of the duct tape. That's exactly what happens in terms of Peyronie's disease. And 7 to 9% of men in the world suffer from this condition. And these men tend to be more devastated. I mean, they are truly depressed when you look at them psychologically to have this kind of curvature. And when the curvature is greater than 60 degrees, they can't penetrate. So it's very devastating.
Yeah. And then for women, when you see women on the flip side, what are their most common complaints?
The most common complaint I see is low libido, right? So many of these women have low libido, but it can be multifactorial. So you can't just say, hey, give them testosterone and the world is great. I mean, there's many things. It's her stress. It's her relationship with her partner. I mean, there's her medical condition. So you have to take into account everything for her low libido. Many women suffer from pain with intercourse, dyspareunia, right? So we talked about that earlier. Many women just have poor arousal, decreased blood flow to the genitalia, and they have orgasmic dysfunction, inability to obtain an orgasm. So you really have to do a deep dive and figure out what is the actual cause. I firmly believe that lifestyle modification for men and women does help with sexual dysfunction. And I will repeat that over and over again. The 4 pillars are
your pillars.
Diet, exercise, sleep, and stress reduction. Diet, exercise, sleep, and stress reduction significantly help with sexual function in men and women. There's something very interesting between the difference between men and women. If you look at a man typically has sex to reduce his stress. He has a very stressful day. He comes home. He just wants to have sex to reduce his stress. In women, it's the opposite. She has to reduce her stress.
Oh, that is interesting.
Right? It's a 180. So if I tell men, if you want to have a better sex life with your partner, reduce her stress.
Do the dishes?
Do the dishes. No, seriously.
I'm serious.
Reduce the stress. If you can reduce her stress, you're more likely to engage in sexual activity. For him, it is for sex to reduce the stress.
I could see where that would create relationship issues, and probably one would have to treat both parties as opposed to treating one party.
You nailed it. It is a couple's disease. When I started my practice in 2007, I was so proud of myself. I was able to get these men these amazing erections, amazing libido. Everything was great. They'd go home and they'd have no one to have sex with. In fact, the women were very upset. They said, look, we haven't had sex in 10 years, and now he wants to have sex all the time. It's ruining our relationship, right? And I thought to myself, they're right. I mean, the reality is that you can't raise one libido without raising the other, or you're going to set up for conflict, right? So if you're going to raise one libido, raise the other. So very quickly, I started getting into the field of female sexual dysfunction. I said to myself, if I'm going to treat the men, I'm also going to treat the women and raise the libidos together, raise the sexual function together. Otherwise, it's a setup for conflict.
You have been saving marriages for decades now, which is incredible. Let's talk a little bit about hypogonadism.
Yes.
And the signs and the symptoms, the definitions, and how one would go about treating that, and what does the evidence show?
Let's go back to like the basic signs, just the basics. So remember that testosterone in men, 90% of testosterone in men is made from the testicles. 10% is made from the adrenal glands. Women are a little bit different. 50% from the ovaries, 50% from the adrenals. Now, there's a signal from the brain, and that signal is called LH, which goes to the testicles and says, come on, let's make testosterone. It's like the gas, right? So if someone has low testosterone, there's only 2 areas the problem can be, from the brain or from the testicles. Either the testicles are not producing or the brain's not producing, one or the other. So my job is to figure out where is it coming from, number one. Secondly, you want to be able to treat them. And you want to understand that giving men testosterone can make them infertile. So many patients who go to these clinics that are 32 years old and they take the testosterone, they come to me and say, no one told me I could become infertile. Now I want to have a child. Well, I have a little bit of an issue. Now we can reverse it, right? But the reality is if you're thinking about taking testosterone and you're planning on having a child, hold off. You can use medications to make you make testosterone. That's safe. I can use off-label clomiphene citrate. I can use HCG. I can use things to make you make testosterone. But do not give a young man testosterone if he's planning to conceive, and make sure he's fully aware that if he does take testosterone, it will shut down his natural production, right? So I think that's very important to have those discussions with the patients. But testosterone, again, is not only for men, it's also for women. I use a lot of testosterone in women, and they also benefit equally as well as men. And I would say for libido, women benefit more from testosterone than men do.
And with the men, when you start them on HCG or enclomiphene or Clomid, do you expect to get a certain percentage rise in free testosterone? If you say, I'm going to give you 3,000 IUs of HCG a week, I expect your testosterone free and total, I don't know, the percentage that it increases to go up by 300 points. Is there some kind of expectation that you have?
Yes. So remember this. When you're using medications to raise a man's natural testosterone, you are dependent on his ability to do it. Some men can, some men cannot. As they age, they're less likely to. So I tell the residents, it's like putting fuel in the car. You can put all the you want. The car will only go as fast as it can, right? So the younger men tend to respond better. So typically what we do is we use HCG or clomiphene citrate, but at some point, the body says, I can't do it anymore. I can't make any more testosterone. But younger men tend to respond. I like to use clomiphene citrate. It's off-label. It's used for women for fertility. But what it will do is it goes to the brain, increases something called LH and FSH. That goes to the testicles, and the man can start producing his own testosterone. Now, I'm a little biased. I believe that Clomid can do something called the discrepancy effect. 40% of men, in my opinion, roughly, will have an increased number in their testosterone, but they don't feel it. They say, Doc, I know my number went to 800, but I don't feel it. And there's a reason for that. The way Clomid works, it blocks estrogen receptors in the brain, and men need estrogen for libido. So they have a bunch of estrogen sitting around. They can't see it. You take that same man and put him on testosterone, he'll say, okay, now my libido's back. So some men who take Clomid will not feel that improvement in libido. HCG doesn't depend on the brain. It goes straight to the testicles and starts producing testosterone. The problem with HCG, it's pricey. It's an injection, it's invasive, and it's pricey, but it works.
I'd like to thank one of our sponsors, Cozy Earth. Now listen, I love Cozy Earth. Here's why. Number one, Cozy Earth makes amazing sheets. And by the way, you want to transform your day? Then you better have a good night's sleep. And we know that the bedroom is not just for, well, sleep. I'm sure that's what you're thinking. Cozy Earth makes incredible, incredible sheets. They are temperature regulating. If you've never tried Cozy Earth, you should. And by the way, my listeners get 40% off, which is basically free. Go to CozyEarth.com and you can use the code Dr. Lyon for 40% off. But wait, not only do we use Cozy Earth sheets, which I have been using for years before they were even interested in sponsoring the podcast. So thanks, guys. Cozy Earth sheets, they have towels, amazing. Makes you just want to, I guess, kind of be naked in a towel. They also have pajamas and they have blankets. You cannot go wrong. In fact, your whole house should be outfitted in Cozy Earth everything. Go to CozyEarth.com and use the code Dr. Lyon for 40% off. And prior to making the decision of putting someone on Clomid or HCG, do you like their LH and FSH numbers in a particular range before you say, okay, this person is going to be a responder? So for example, the people listening, blood work is now highly accessible to individuals. And maybe they'll go on Inside Tracker, or maybe they'll go on some way to get their blood work that's direct to consumer. Could they, and also we have lots of physicians and healthcare providers listening, say, okay, well, the LH and FSH are 3 or under 3 versus, say, 10. How do you decide?
Great question. So remember, as the testicles start to fail, your LH and FSH go up, right? So the higher the LH and FSH, the less functioning the testicles are. LH is a good marker of the testosterone production. FSH is a good marker of your sperm production, right? So in men. So as I go up, this less functional. So in men, if the LH and FSH are high, typically HCG and Clomid will not work, right? And the number you want to think about is 7.6. It's a good number. It's been shown that that's kind of the cutoff. So if his FSH and LH are 10, 15, probably not going to work the best. It may have some mild benefit, but not really work that well at all. So in those cases, what you want to consider is a third medication. Again, off-label. It's called anastrozole or Arimidex. It's been used typically for women with breast cancer. And what it does is it blocks the conversion from testosterone into estrogen, right? So essentially, instead of making the man make more testosterone, you're preventing him from losing what he's got, right? And so we use a lot of Arimidex or anastrozole in those men who have elevated LH and FSH. So it's important, you're right, look at the LH and FSH. If it's high, giving them more HCG or Clomid will probably not work. If it's below, it will work. And we typically use Clomid off-label.
You do. And when you start with an anastrozole, the dosing is relatively low. We
Very
spoke
low.
about it. It's different than what people think, or a lot of the TRT clinics are giving individuals 1 milligram 3 times a week. It has negative effects on bone density.
You nailed it. So this is very important. I used to think that testosterone was the key driver for libido and sexual function, but there are many studies that have shown that it's the estradiol. It's the conversion from testosterone into estrogen, which gives that man that libido and improvement in sexual function. This was the Finkelstein study. And so what we know now is if you block a lot of the estrogen, these men will complain of low libido. So I call it the sweet spot. You don't want the estrogen too high, but you don't want the estrogen too low. I personally like to keep it between 30 and 50 in the sweet spot. So when I first started my practice, I thought estrogen was for women, testosterone is for men. I'm going to give them a lot of anastrozole and shut them down. And it was a big mistake, right? And now what we do is we manage it. We give them a 0.5 milligram once a week, just enough to get them from high back into the normal range. And that works really, really well. So getting those men in the normal estrogen level is very important. Estrogen is extremely important for men. It's not just for women. It's extremely important for men, particularly when it comes to sexual function. It's very important.
That's relatively unknown. Individuals listening probably have never thought about estradiol for men for sexual function. You'd mentioned it. You really like to see the range between 30 and 50. Is there any evidence that above 50 would be a problem?
I think that there can be an adverse. The main one is gynecomastia, right? So as the estradiol level goes up, men can get breast tenderness. And I've seen personally that I see that men typically can get some mood lability as well when the estrogen goes up so high. So what's the point of keeping the estrogen so high? Why do I have beautiful, wonderful medications that can bring them back into the normal range. My only request is not to shut them down. Because in the old days, we said, just give them 1 milligram a day. They don't need it. The reality is they do need it. So if someone's high, just bring them back to normal, but don't shut them down. We also need it for bone mineral density. So men also can get osteopenia, osteoporosis, and taking away their estrogen, particularly for 2 years or longer, can result in osteopenia and osteoporosis.
That's really important when you think about, again, what you talk about, these overall pillars of health and these lifestyle factors. When you are replacing testosterone, so typically when they're young, you don't like to do it. For people that want to have children, fertility issues, again, you said that it can be reversed. Over time, I know that I've read many of your papers that there's a certain strategy. You start them on HCG to help, and then if that doesn't work, you would consider also adding in Clomid. I am curious about the dosing of Clomid, and we're talking about Clomid. Is there a place also for enclomiphene?
Right.
And how do we dose Clomid? People ask, can you be on it for 5 years at a time?
Right. So Clomid is dosed. I dose it every other day. And the reason I dose it every other day is because if I dose it every day, 7% of patients will become resistant to the drug. We call that tachyphylaxis. It's roughly 7%. We don't see tachyphylaxis on Clomid if you dose it every other day. Enclomiphene is not FDA approved, so it never made it through the FDA. But if you think about Clomid, it has something called a cis and a trans isomer, cis and trans isomer. And the trans isomer alone is clomiphene, right? So Clomid has cis isomer and trans isomer, and clomiphene has just the trans isomer. It's a shorter half-life, and we did a recent publication, an abstract that we presented, showing that patients typically have less side effects, and they may have more benefit with the enclomiphene, but still not FDA approved. it's compounded typically. But Clomid is readily available. It's a fertility drug for women that we use off-label in men, and the dosing, again, is every other day. But Clomid, as I mentioned, can have that negative effect where some men will come back to me and say, I have no desire for sex. I have a low libido. And I know my number says 800, but I just don't feel it. So I explain to patients before I give them the medication, okay, you may have this effect. If you do, we'll switch you to HCG. But if you don't, great. It's cheap, it's effective, and it's commonly used.
And it can be used every other day. Do you start them at 25? Do you start them at 50? How would a provider or a patient or a person listening go and speak with their provider about that?
Yeah, so I typically do 50 milligrams every other day. Now, some patients say, look, doc, I can't remember every other day. Sometimes I do one day, I forget the other day. I say, fine, take 25 milligrams a day, which is half a pill, and you may become resistant, 7% chance. 93% chance you won't, but if you get the 7%, we'll deal with it, you know? But again, it's a reality. You can become resistant to the drug. So we try to do it every other day.
And how long could someone stay on that if they're getting good benefits?
Great question. So you can be as long as your testicles can produce, you can be on it, right? So at some point, so the testicles tend to atrophy. We undergo apoptosis, 1 to 2% every year, starting in your 20s. So the longer you live, there's greater cell death in the testicles. Eventually, they will stop producing, and your testicles will say, I don't care how much Clomid you give me, I'm done.
I'm out.
I'm out, right? And at that point, you make the switch over to testosterone. Now, typically, though, if a patient is not interested in fertility and they're a little bit older, it makes more sense for me to start them on testosterone supplementation because I think they tend to feel better on exogenous testosterone, and it's a lot cheaper, a lot cheaper.
Yeah. And there are different forms of testosterone. There's now an oral form. I'd love for you to break down testosterone replacement and the forms.
Yes. So there are so many different. When I first started, there's essentially gels and injections and patches. We don't use patches anymore.
I was like, there's patches?
Yeah, patches, androderm. There was one patch that was actually placed on the scrotum that they thought would be better. Now, then there was androderm, not commonly used because 37% of patients would get a very bad skin reaction. You have to take the patch off every day. Now, the gels are very commonly used, but the problem with the gels is that they're dependent on skin penetration. So let's say I put a gel on your body and you get 0 skin penetration. You get nothing. Let's say you get 10%. That's great. If someone gets 80%, that's even better. So we're so dependent on skin penetration. So there's numerous others. Injectables are very popular.
And before you move on, the gels, so someone would not be able to know going in, is it based on skin type?
Right. So everyone's skin's different, and some patients' skin has better penetration than others. But one important thing about the gel you bring up, you can get transference.
Right.
If you have a baby at home or a pregnant wife, you do not want to prescribe a gel to that patient because of the risk of transference. So I think you got to be very careful. But because of the variable absorption, poor penetration in many cases, most patients, as long as they're not needle phobic, like the injections because you can do them sub-Q. Now, they are the ones you get like testosterone, nantate, and cypionate are off-label sub-Q, but they're meant to be intramuscular. But there was a medication called Xiasted that came out several years ago. And Xiasted essentially is just a spring with testosterone and nantate in it, and it's meant to be sub-Q. And typically when you inject someone sub-Q, you can use less testosterone, about 20% less. So if I have to use 100 milligrams IM in a patient, I can use 80 milligrams sub-Q. The starting dose for the Xiasted, the sub-Q testosterone nantate, is 75 milligrams. So testosterone injectables are great. There's long-acting injectables we have in the United States. We have Aved, which is a 10-week long-acting injectable. But most people like the short-acting because they're cheap because you can get it from a compounding pharmacy, and you can get cypionate or nantate are the most common. Now, I tell the residents, how do you know between cypionate and nantate? How do you know which one to use? I say, think of C for child, E for elderly, right? And kind of use the number 50 to 60 years of age because if you cypionate has more sodium retention It's more anabolic, so you can get more swelling, and it's a slightly longer half-life. Enanthate is less anabolic and less sodium retention. So I typically, if I give a 75-year-old man some cypionate, he's going to have some swelling in his feet, more edema. So I try to give the older patients enanthate, the younger patients cypionate. But these two medications are fantastic. And quite frankly, you can use them interchangeably slightly because the half-life's relatively the same. If you run out of enanthate for someone young, and you can use cypionate. But very effective, very cheap if you get them from a compounding pharmacy.
Yeah.
And we have our patients inject sub-Q. I think sub-Q works far better. And I think they should inject twice a week. And I have them inject on Sunday and Thursday. And the reason being is because they peak in 24 hours. So if you inject Sunday, you're ready for Monday. If you inject Thursday, you're ready for the weekend, right?
Right.
So I do half dose, I split it. Otherwise, I have these huge peaks and troughs if I don't split it. And I just like to have a much smoother graph.
When you do sub-Q, does that change the conversion to estrogen? Is there less estrogen conversion or estradiol conversion? Is there are there other mechanisms that make the person be able to use less?
The absorption is better. The only key thing is you can use less testosterone, but there's no other kinds of conversion. Remember, most of the conversion is when you see on the skin, right? But this is beyond the skin. You're going into the fat. But we feel that I've seen that better absorption of the medication. It doesn't matter if it's enanthate or cypionate, better absorption systemically when you use it sub-Q. So that's why you use less dose. And that's why the starting dose for Xiasted is 75 milligrams, where most people are taking 100 milligrams IM, that little conversion. So if you're using sub-Q, just remember you're going to get better levels, and you may need to go down a little bit on the dose to compensate. Patients love sub-Q, much better than IM. It's easy. If you're not using Xiasted, which is an auto-injector, you can draw it up yourself.
Yeah.
You can inject sub-Q, and you can do it Sunday, Thursday. Very, very effective, very cheap, and patients are very happy.
And what percent, just in general, what percent of testosterone gets converted? So, for example, if someone comes in and their testosterone is 300, they feel like crap, their free testosterone is low. Do you say, well, I'm going to start you on 150 milligrams. I expect your testosterone to bump up to X, and I don't know, 0.6% or 6% will be converted to estradiol.
Yeah. So this is the way you want to think about it. Everyone's different. But if you look at testosterone, 0.3% is converted into estrogen. 6 to 8% is converted into dihydrotestosterone. So those are the numbers you want to remember. Now it can vary because obesity, fat cells contain a substance called aromatase. And aromatase eats the testosterone and converts it into estrogen. So in patients who are obese, they tend to have more conversion into estradiol. But the good way to think about it is 0.3% for estrogen, 6 to 8% for dihydrotestosterone. Now, what's the problem with that conversion? If you have too much estrogen, you can get gynecomastia, right? And I also believe that patients who have too much estrogen can get some mood lability as well. If you have too much dihydrotestosterone, you can get male pattern baldness, right?
For men and women.
For men and women. So how do the drugs work, like Propecia and these medications? They block the conversion from testosterone to dihydrotestosterone. I'm not a big fan of these medications.
I was going to say Propecia.
Yeah, I do not believe the use men and women should use this medication. I think it has significant negative side effects, and some can be permanent. That's how it works. So essentially, if you have a patient who's getting too much estrogen, what you can do is you can put them on a low dose anastrozole, estrogen blocker. And when you block that conversion, estrogen comes down and their testosterone goes up. So you can work around it. But I think it's very important to follow the testosterone and estradiol and DHT in these patients.
And is there a number of DHT that you like to see?
Well, I try not to shut it down. I try not to mess with their DHT at all. I really feel that what I've seen with irreversible sexual dysfunction, suicidal ideations, terrible side effects with shutting the DHT down, I don't believe in doing that. So I will not prescribe medications that shut down DHT.
Which would be Propecia
and finasteride. I will not. But I'll do a workaround. And so there are medications. Patients will go for hair transplant, or they may look at, because the main thing is hair loss, right?
Right.
That's the main thing.
Practice,
that's what they worry about, right?
Just had a conversation with a woman who her testosterone was low.
Yeah.
But she really struggled with hair loss.
Yeah.
and she wants to go on testosterone, she needs testosterone, and she's already on oral minoxidil, things, you know, looking at her copper, her iron. What would you do in a situation like that?
So oral minoxidil is very good. You can use a 1.25 milligram. These are off label, but it does help. Remember that you just tell the patient when you use oral minoxidil, you're going to lose some hair first, and then it's going to come back. Right? There'll be a dip. Excuse me. There'll be a dip. The second thing you want to let them know is that you can use topical minoxidil also. It doesn't have to be oral. That can be very helpful. But I really do not want to give them medications that will mess with their androgens orally, particularly like Propecia. I just feel like it can have a negative adverse effect. Look, I'll just tell you. So we did a study. I got looking at Propecia in men, the effects of something called post-finasteride syndrome. And in my study, there were 25 men that came to me from all over the world. They came from South Africa, Scotland, everywhere to be in my trial, because when they took the finasteride, they had negative adverse events, not only sexual dysfunction, but they also had depression, low libido, poor cognition. And in my trial, during my trial, 2 patients committed suicide.
Oh my gosh.
Because of increased suicidal ideation. And so I am very averse to giving patients finasteride. I just feel like, because remember, in medical school, we were taught that testosterone, Propecia, these medications block the conversion from testosterone to 5-alpha reductase. It has a negative effect, and it blocks the conversion to DHT. But we weren't taught about the other 12 pathways. We were taught about that one little pathway, testosterone, DHT. You give them finasteride, it blocks the conversion. But the other pathways are extremely important because they block the conversion to what we call neurosteroids in the brain and allopregnanolone, which are responsible for depression, anxiety. So some patients that are taking this will say, I have anxiety, depression, suicidal ideation. Many countries have put on their package insert, increased suicidal ideation if you take finasteride. In the U.S., we haven't yet, right? But many countries have already said that. So I think it's very important that patients know finasteride can have a significant adverse effect mentally and with depression.
That is really important. You guys, if you are taking Propecia or a finasteride, this might be something to really, obviously we are not your physician, but really consider removing from your plan. There are better options.
Yes.
That's safe to say.
Yeah.
For DHT, that is more anabolic. Yes. It's more anabolic than testosterone. It's really important. I'd like to take a moment to thank one of our sponsors, Fatty 15. Yeah, the name is a little weird, but it's exactly that. It's an essential nutrient. Fatty acids are critical. And C15, I have to say, I was very impressed with the founders. I met them at one of the nutrition conferences, and I learned all about Fatty 15, which is why I'm excited to bring it to you. Here is what Fatty 15 does. It is very good for cells. Cells incorporate fatty acids. You want them pliable so they can move as opposed to stiff and exposed to oxidative stress, which happens in everyday life. Fatty 15 is research-backed. It's good for mitochondria. It plays a different role than omega-3 fatty acids, and it doesn't go rancid. So you are taking an essential fatty acid, hence the name, Fatty 15, in a way that it doesn't go bad in your body. And I think that that's really important. And most people are deficient in this essential nutrient. You can try yours by going to fatty15.com/Dr. Lyon. And no doubt you will get 15% off your first 90-day supply. That's fatty15.com/Dr. Lyon. Is there a number, a target number that you like to see for men, 80 or 100, or is it, again, very variable?
Yeah, it's 40x. So like testosterone, DHT is 40x, but I don't like shutting down their DHT for the reasons I mentioned with Propecia, right?
Do you want it higher? Is there a target?
My target is typically on the T. I look at the T level, and the T level typically is 300 to 1,000. Now, if a man comes to me and some your physicians say, he's at 400, he's normal. That's not, may not be normal for him. The reality is we did this wonderful study several years ago looking at something called the sensitivity of the androgen receptors. These are called CAG repeats, right? So
that's on my list. I'm so glad you brought it up.
So the higher the CAG repeats, so 27 or higher, the higher the CAG repeats, the more insensitive the androgen receptor is. And we showed several years ago that those patients who have more insensitive receptors need more testosterone. Makes sense. If you have more sensitive receptors, you may need less testosterone. So how can you assume that every man, the cutoff right now is 300, above 300 is normal?
And it seems like it keeps getting lower.
Well, in some cases, right? So, and we'll talk about that. Every man, if you're above 300, you're normal. If you're below 300, you're not normal. That's not true. Every man has his own cutoff. Every woman has her own cutoff. So if the range is 300 to 1,000, what we found is if you put the patient in the upper quartile of normal, then most of the patients have met their cutoff number. So if a patient comes back to you and his number is 450 or 500, and he says, "Doctor, I still have symptoms," the response should not be, "Well, you're in the normal range, so let's find out if something else is going on." The response should be, "Let me raise your testosterone even more in the normal range, because some patients will continue to see benefit," right? That should be the response. And same with women as well. So I think it's very important to realize it's not one number fits all. It's a range, and you sometimes need to take patients into the upper quartile of that range to see symptomatic improvement.
And if someone has a CAG repeat and they're insensitive, they're androgen insensitive, typically providers will not go over 200 milligrams of testosterone weekly. But what I'm hearing you say is potentially people might need more and they just don't feel it. Would that be reasonable to say?
Absolutely. So some patients, we're all different.
Right.
Genetically, we're all different. You can't assume that everyone's going to feel great at a certain number. And certain patients we all feel great. Maybe this gentleman over here needs an 800. Some men just need 400 and they feel great. And it gets a little deeper. You got to look at the free testosterone also, because if the SHBG is elevated.
And we should definitely talk about that.
But it is not one number fits all, right? Everyone is different, and every man and woman have their own cutoff. And you just want to get them above their cutoff in order for them to see symptomatic improvement. And I'm not saying you have to go super physiologic, but if
what if someone doesn't feel it? If they're very androgen insensitive,
yes,
and they're on what we would consider the max dose of testosterone. So the max dose of testosterone, and correct me, according to the guidelines, would be 200. People wouldn't go.
Well, don't go on the dose. Go on the number of their blood tests, right? Because some patients, I need to put them at 200 just to get them into the normal range. Like, it just varies, right?
Okay.
So some patients will need 250, 200, 150. It varies. I'm looking at their blood tests, and I'm also looking at two other things. I'm looking at their risk of erythrocytosis. So if someone has too high of a red blood cell count, there is a theoretical cardiovascular risk if it's above 54, right? So testosterone increases the red blood cell count, right? So
for everybody, well, do some people respond differently and there isn't erythrocytosis?
Right, but it depends on the formulation you use. So we published a study looking at all different types of formulations. If you give someone an injectable in our study, it was 68% chance of having erythrocytosis. If you gave someone a pellet, it was 35% chance of getting erythrocytosis. If you gave them a gel, it was 12% chance. The orals, which we'll talk about, what's nice, it's 5% chance.
So much less.
So much different, right? So if a man comes in and he's saying, "Look, my red blood cell count keeps going up," what I have them do is I have them donate blood. That's one option. Or you can have them decrease the dose. Most of them don't want to decrease the dose. So we have them donate blood. And we typically have them donate 1 pint separated by a week to drop that blood count, because most men don't want to stop the medication. But another smart option is, okay, injectables have a 66% chance of erythrocytosis. I'm just going to switch you to an oral. I drop it down to 5%, and he doesn't have to donate blood so often. Now, some men don't like orals. They like the injectables and the way they feel, but it's that peaks and troughs that causes the increase. There is a theoretical increased cardiovascular risk if someone gets above 54 on the blood count. So that's why we want to stay away from that. Now, I just want to be fair. I want to stress theoretical. Right?
I just
want to stress theoretical because
bring that up to you.
Until 2022, before that year, there was not a single study to show that secondary erythrocytosis, meaning if I give someone testosterone and their blood count goes up, they're at a higher risk for getting a cardiovascular event. That was never shown. It was only shown in patients with polycythemia vera, which is a blood cancer, right? That shows that if someone has polycythemia vera and their blood count goes up, they're at increased risk for having a cardiovascular event. That was never shown never shown with testosterone. There was one study out of the University of Miami and showed a 1% difference, mild, but this was a database retrospective study saying that maybe there's an increased risk. So just be very clear, testosterone is theoretical risk if that blood count gets too high.
But how do we reconcile that? Because again, you said it's a theoretical risk. When you administer testosterone, depending, then the erythrocytosis would be something that we would expect. I think that there's the hematologist, I'm not sure that I think that they have guidelines that they are not necessarily concerned. I don't know if...
To some degree, you know, there
That's
are,
true.
I think that, you know, the numbers that you want to remember is 54. Above 54, we ask our patients to donate. In fact, at 51, I ask my patients to donate blood because why am I waiting to the trouble number of 54? Just preempt it. Do it ahead of time, right? And some guidelines will state that at 52, don't start the testosterone. So if the hematocrit's above 52, don't start. So we will live within the guidelines, and that's fine. I'm happy to live within the guidelines.
And the guidelines, you feel, obviously they're important because they set the standard of care.
They set the standard of care, and so what you can do is very simple. If you have someone on an injectable and he's getting erythrocytosis, switch him to an oral, switch him to a gel, maybe switch him to a pellet, and it drops it. Or they can continue to donate. They can donate blood and keep their levels low. And some men are perfectly fine with that. Now, remember this. Some patients, this is very important, some patients that keep donating actually have underlying obstructive sleep apnea. They have and we catch it, right? And it's manifesting now because they're taking testosterone. You send them for a sleep study. They have sleep apnea. You treat the sleep apnea. Guess what? They stop getting the erythrocytosis with their injectables, right? And so we can unmask a lot of sleep apnea just by putting these men on testosterone injectables.
That's really important. I know that you really believe that sleep is important for overall health, cognitive function, sexual health. Do you think that there's a risk, because they're in the guidelines, that if an individual's hematocrit goes up and we ask them to donate blood, it could probably, I mean, it does, it lowers their iron stores.
Right.
And so, again, we're functioning within the guidelines, but do you think at some point that those guidelines are going to be reevaluated?
Well, they are. So one that's going to be reevaluated is the cardiovascular risk. So the cardiovascular risk was in the guidelines, and they were in the 2018 testosterone guidelines. But I got to tell you a little bit of a story. So here's the story.
I love a good story. I love a good story.
For decades, we gave men testosterone, and the studies would show that men with low testosterone levels were much more likely to have a heart attack. That's interesting. Molly Shores in 2016, one of the first to show men with low testosterone more likely to get a heart attack. Many prospective studies after that. And then there was this concept that maybe if you normalize the testosterone, it potentially could decrease your risk for heart attack. But in 2010 to 2014, there were 4 studies that came out saying that if you give men testosterone, you will increase their risk of having a heart attack. 3 of those 4 studies were retrospective, non-randomized database studies. So some limitations. So the FDA in 2015 said, look, we want a well-designed trial to make sure that testosterone does not cause a heart attack. And in fact, we're going to put a warning in the package insert saying that it could increase the risk of cardiovascular events. And until you give us this trial, we're going to leave the warning there. So this trial was called the Traverse trial, an amazing trial. The largest randomized placebo-controlled trial in men looking at does testosterone.
Over 5,000 men.
5,200 men, big deal.
5,246.
That's right. It's a big deal.
Yeah,
and we've never had
massive.
And so I was one of the investigators in this trial and basically helped design this trial. And we basically not only looked at cardiovascular risk, but we decided if we're going to do this trial, we might as well look at other things as well. So we looked at the risk of prostate cancer or high-grade prostate cancer. Then we looked at 5 other domains. We looked at risk of diabetes. We looked at bone fractures. We looked at sexual dysfunction. We looked at anemia in these trials as well. And so the gist of the story was this, is that when we did this trial, over 5,200 men randomized to testosterone gel or placebo.
45 to 80.
That's right, 45 to 80. And that's important because there was a trial before this called the T trials. And the T trials only looked at men over the age of 65, right? But this trial looked at all men above and below 65 years of age. What do they find? No increased risk in cardiovascular events. That's really important. Right?
No increased risk. So this is a multi-center randomized controlled trial, over 5,000 men between the age of 45 to 80.
Yes.
No increased risk of cardiovascular disease. on testosterone.
And we did something very interesting. We only selected patients who were at high risk.
I know.
Right?
It's an extraordinary. The study will link it.
Yeah.
Extraordinary.
Yeah, think about it. In order to be in this trial, you either had to have cardiovascular disease, meaning cerebral vascular disease, cardiovascular disease, or you had to have risk factors for cardiovascular disease, diabetes, hypertension. So these patients were already at high risk for having a heart attack, right? And in that study, and even despite giving them testosterone, we saw no increased risk of cardiovascular events. Now, you should know about 3 little exceptions in the study. We did see a slight increase in those patients who had renal insufficiency, very tiny. We had a slight increase in pulmonary embolism, very slight, from 0.5 to 0.9%, so it was very tiny.
It's very small.
So that I think that's very important to realize that there were some slight curveballs, but at the end of the day, no increase in cardiovascular events. Now, look at all the other studies that came out of this. It was fantastic. We saw that there was no increased risk in prostate cancer. That's very important. We saw that there was no increased risk in BPH or lower urinary tract symptoms. It's in the package insert. If you give a man testosterone, make sure you follow his urinary symptoms because it could get worse. That's not true. That's not what we saw. In fact, most of the studies, not the Traverse trial, most of the studies show that long-term testosterone in men either have no effect on their urinary symptoms or an improvement in their urinary symptoms because testosterone can be a strong anti-inflammatory for the prostate.
That's a lot of reconsiderations that we have to think about from the patient population to provider, because just number one, people will say, well, I can't go on testosterone. I'm afraid it's going to affect my heart.
Right.
I don't want to go on testosterone because I'm afraid it's going to cause BPH and keep me up at night.
Right.
These are really important things that actually prohibit people from taking action to improve the quality of their life by the utilization of hormones.
We needed the Traverse trial because when the Traverse trial first started and the FDA talked about the risk of testosterone cardiovascular disease, if you look at a graph, the utilization plummeted in men. It plummeted in the use of testosterone. This was a fear that if they took it, they'd get cardiovascular risk or any kind of cardiovascular disease. But how unfortunate, because many of these men were benefiting from the medication, but they stopped it because they were fearful that they may get a heart attack. But they actually didn't need to stop it because they were benefiting as well. So that was those two were the big findings, cardiovascular and prostate. But there were other findings as well. There was improvement in sexual function. Now, there's 2 types of sexual function. There's libido and actually erectile function. Testosterone as monotherapy still should not be indicated for pure erectile dysfunction. It does help when someone's taking Viagra. Let me give you an example. Or Cialis, or we call these PD5 inhibitors. If a man says, look, I've been taking Viagra and things have been great, and all of a sudden my Viagra stopped working, if you check his testosterone and it's low and you replace it, 30 to 50% of men will say, you know what, my Viagra's now working again, because Viagra and testosterone work very well together. But in the guidelines, testosterone as monotherapy is not meant to be used for erectile function, but it does help with libido. In the Traverse trial, we did see a significant improvement in desire and libido. What are the other things we saw? We saw improvements in anemia. That was very important as well.
That makes sense.
We didn't see any improvement. We saw improvements also as a sexual function. We saw improvements in anemia, but we didn't see much improvement when it came to other conditions, such as diabetes.
That's interesting. Because you would think it would improve skeletal muscle mass, but if they're not exercising, it's not going to make a
Now,
difference.
there's a big difference because there is a very famous study called the T4DM. The T4DM study showed that if you give men testosterone, it actually improves insulin resistance.
Right.
But in this trial, it did not show improvement. Now, the T4DM used a different medication. They used something called Nebido, which actually has high levels of testosterone, gets them well into the supraphysiologic or normal range. But in our trial, if you were above 350, you were considered normal. So if you have a testosterone level of 370, then some would say that's really not high enough to see symptomatic improvement in insulin resistance. So I think there's some limitations with this trial to say, did we see improvements? We did see improvements in anemia. It makes sense. If you give someone testosterone, anemia, blood count goes up in the Traverse trial. But I think it's very important to realize that there are a lot of benefits of testosterone. It's just not about sex.
Right. What about for women? The the numbers for women are much lower. If an individual is looking at their labs, their free testosterone would be considered normal, even if it's 1.
Yes.
Do you think that those numbers are correct? My patients seem to do and feel much better when their free testosterone is higher than these lab values that we're looking at. And it's very clear.
Yeah. In women, free testosterone is far more important than total testosterone. And the problem is that her SHBG can be completely variable. So
just sex hormone binding globulin.
Right. And sex hormone binding globulin is bad. So the higher the SHBG, the less the free T, right? So what is the number one cause of elevating SHBG? Birth control pills skyrockets the SHBG. Now here's the clincher.
And copper.
Yeah, right. But here's the clincher. The clincher is that did you know that if a woman takes birth control pills greater than 5 years and then decides to stop, many of her SHBG levels will not normalize. They'll stay permanently elevated.
Wild.
Right? So many years
ago. Is that
in
the package insert?
You're reading my mind because I was about to say many years ago we tried to put it in the package insert and we couldn't get it in because causing irreversible sexual dysfunction in women. Irreversible. And because if the SHBG stays high, I don't care what her testosterone is, the free testosterone is going to be very low.
Would there be any way to overcome that if you dose it high enough?
Yes. So the only way to win is to increase the total T to overcome, and you can have a higher free T. But you have to be able to follow that. Follow the free T in women, not the total T. Follow the free T. It's very important. So I think that women are a little bit different. You have to pay more attention to the free T. You have to be careful on how fast and how much testosterone, how much of a rise, because she can get acne or facial hair, right? And so in men, if you overshoot, you can just bring it back down. In women, you start low and you move up very, very slowly on those doses. So,
do you like injectable for women, sub-Q?
I do. So I think the transdermals don't absorb very well. And the way you want to think about the dose for a woman to men is it's 1/10 the dose. Now, remember, testosterone is off-label for women in the United States.
Why is that? Why?
Yeah. So they tried many years ago. Intrinsa was a patch that they were trying to get through the FDA and just never got through the FDA. I think it's a shame because women benefit, I think, even more than men when it comes to testosterone supplementation. Let's talk about bone mineral density for them, libido, cognition, just overall well-being. So, but it didn't get approved. So typically for women, I'll either use a testosterone pellet, I'll use a cream, which is compounded because there's nothing FDA approved, or I'll use an injectable. But most women will go to the pellet or they'll use the injectable. And the way I use my injections is, again, sub-Q. And you just have to dose it different and use typically 1/10 the dose.
1/10 the dose. And do you have any concerns being outside of range? And this is more for, both the listener and the providers. Do you have any concerns about that?
I think the main concern is for women, I can start getting acne, facial hair.
But what if they don't have any of those side effects and you are outside of the normal range?
Yeah.
They feel great.
Yeah. The other thing I worry about is in terms of erythrocytosis, right? So there are some other things that can occur. I typically like to keep them in range, but the upper quartile of normal.
And I just pulled this up. This is, again, the lab values are going to be different, but this is 0.5 to 2.4 nanomoles per liter.
Yes.
So small versus a male could be, again, the total would be 300 to 1,000 nanograms per deciliter or 10 to 35 nanomoles per liter.
Yes, but this is very important. Why are we so fixated on the number? Let me just put that out there for you. So if you treat a woman for estrogen, she says, doctor, I'm postmenopausal and I have hot flashes. So I say, sure, ma'am, I'm going to start some estrogen. And so I don't check her level. She's postmenopausal.
Right.
And she comes back and she says, my hot flashes are better, but I still have some. I'm bothered by them. I don't check her levels. We just give her a higher dose of estrogen. Why is this any different? I mean, to some degree, we're so fixated on the number.
I completely agree with you.
Yeah, this is symptomatic improvement, not a number.
Right. And I bring this up because let's say a woman is at 2.4, just even from a medical legal standpoint, that's not enough for her.
Yeah.
And let's say she's still completely symptomatic. You push her to double that.
Yeah.
And she has no erythrocytosis and feels so much better.
Yeah. I agree. So we're so fixated on the numbers. And many times before I tell the patient their lab values. I say, how do you feel?
Same.
I say, how do you feel? He doesn't feel great.
Same.
Because sometimes if I say your levels are low, he says, well, by the way, I don't feel that great. And I say, no, I want you to tell me how you feel first, because that's very important. Yeah.
And for women, you'll use a sub-Q injection, or cream.
Or a pellet.
Or a pellet.
Those are my 3 favorite. So, typically I will, again, this is off-label, but she will compound at 50 milligrams per ml, and she'll start out at 0.1 ml once a week, and it's sub-Q, and it's easy if she wants to do the injection. I'll compound the cream at 4 or 8 milligrams per ml, and that's easy. But, the cream sometimes has poor variable absorption.
Yeah, it seems that way.
It can be tricky.
It seems that way.
It can be tricky. And then a lot of them love the pellet, and so they'll come in once every 4 months for a subcutaneous pellet that's placed on the side of the hip. Very effective. And she's autopilot. She doesn't have to think about it. And so she likes it.
And what about alternative treatments for women who, let's say they have concerns about going on testosterone? You and I were talking about Addyi.
Yes.
I would love to hear your thoughts on the alternative treatment.
Yes. So Addyi's nice in the sense that it has no hormones, right? So if a woman says, I have a history of breast cancer, the beauty about Addyi is it doesn't increase the risk of breast cancer, right? Not like so basically Addyi increases dopamine in the brain, can increase norepinephrine, and these hormones increase the desire for sex, right? So Addyi's been around for a while, and many patients will use the Addyi, and sometimes in conjunction with the testosterone, to help with libido. But what's nice about Addyi, it is FDA approved strictly to increase a woman's desire for sex, and it can be very effective. So several years ago, I said to myself, if Addyi is good enough for women, why don't I use it for men? So I went to the FDA, and I actually got an IND from the FDA to be able to get permission to give it to men. So I have the only IND in the United States to give Addyi to men strictly to increase their desire for sex, right? Because men and women are not that different. If I increase dopamine in a man's brain, if I increase norepinephrine in a man's brain, he also wants to have sex, right? So Addyi is a great medication, very effective. There's one other medication out there.
And before you continue, would there be any reason why someone wouldn't go on Addyi?
Well, not really. I mean, there's some side effects. You can get some nausea. There are some side effects. I tell patients to take half a dose every day for 2 weeks, and then you can desensitize yourself and then go up to the full dose. There's a cost, and some insurances don't cover it, but it's cost pretty reasonable for 3 months. So those are some of the things. And I tell patients if you don't benefit after 3 months and don't,
so it takes about 3 months for efficacy.
Great point, because I said you don't expect, if you don't see anything in a week, don't quit. Right.
Don't quit.
You give me 3 months. At the end of 3 months, if you see benefit, great. If you don't, we can move on. But I do think that many men and women do benefit from it.
And because because it works in a different pathway, it works in the brain, could you potentially use it in combination?
Absolutely. So that's where it works the best. If you use testosterone and Addyi primarily for sexual dysfunction,
that's what we've been.
It is very
doing.
effective because it's 2 different mechanisms, right?
Yeah, and not to mention, it seems like Addyi has side effects that I don't know if they lose weight, they sleep better. It seems as if there's these other benefits.
So 100%. So 2 other things that patients will talk about is weight loss and sleeping better. And so many women say, I'm in.
Right.
Increase sex, weight loss, and sleep better. But
those,
in the
water.
But again, those are side effects. The main goal is libido. Now, look, I just want to be very clear. Addyi is phenomenal, but you have to also work at it too. I mean, it's part of your relationship. I can't fix your relationship with your husband.
I don't know. You can do a lot of things.
But with Addyi, I mean, you have to work on it, and you have to give me the 4 pillars. Give me diet, exercise, sleep, stress reduction. It's a program, and you can add the Addyi in, and it works beautifully. But if you think that I'm going to take Addyi and everything's going to be perfect with no work, really, it's really synergistic when you put the work in.
This episode is brought to you by Inside Tracker. You've heard me talk about Inside Tracker many times. Why is Inside Tracker important? Well, you have to know what's going on in your body. Otherwise, you are just kind of out there with blindfolds on, and nobody wants that. Inside Tracker is an amazing blood work, biomarker, full platform. It includes technology. It includes wearables. It includes blood work to show you exactly what your biomarkers are, things like insulin and glucose and thyroid and hormones, all of the stuff that you should care about. And Inside Tracker makes it available for you. Inside Tracker has been very generous and is giving 20% off to all of my listeners, the entire store. You can go ahead and pick whatever program that you want. Some of them include fitness tracking data. Others include biomarkers, many different biomarkers. I use Inside Tracker myself. You can too. Go to insidetracker.com/Dr. Lyon for 20% off. That's insidetracker.com/Dr. Lyon for 20% off. Now back to the episode. Just because you mentioned exercise, there is a paper here, Effect of Aerobic Exercise on Erectile Function, Systematic Review and a Meta-Analysis of Randomized Controlled Trials. Could you mention the impact exercise has on sexual function?
Yeah, we published this just recently, and it's really important. So patients come to me and say, look, I don't want to take a drug. I don't take a pill. What can I do naturally to improve my sexual function? And this was a study looking at exercise, and it was a meta-analysis. We looked at 11 randomized placebo-controlled trials looking at the effects of exercise on improving sexual function. And what we found was that on average, the IIEF, which is a score for sexual function, improved by about 3 points strictly with exercise alone. And what's very interesting is the more severe ED you had, the greater the improvements you would see in sexual function just by exercise alone. So I can't stress the importance of diet, exercise, sleep, and stress reduction. I call those the 4 pillars. You have to, and you and I, both of us, can do better on diet, exercise, sleep, and stress reduction. And every day when you wake up, every night when you go to sleep, ask yourself, what am I going to do better on those 4? Because to me, those are the key.
What is the one you have to work on? I know the one I have to work on.
I have to work on all 4, but I would tell you this. I think that I can always do better. I'm always hard on myself. I have to do better on all 4. But, I think stress reduction, because stress is, it's what we do is high stress, but you got to find ways to take time out. And, most of my CEOs are really good at diet and exercise. They go to the gym.
Right. That's actually
they eat healthy.
The easy part. That's the easy part.
But when it comes to sleep and it comes to stress reduction, they're lousy.
Yeah.
They're lousy. And they say, well, I can, because the sleep in many ways is not in your control somehow, and so it's how you process. So diet, exercise, we got it. Most of my guys are lousy on sleep and stress. Now, a lot of them are successful because they manage stress well. Like that's how they got there.
Right.
But sleep is the tricky one. You got to get the sleep down. It is critical for overall success.
The thing that's so interesting here is we talk about healthy lifestyle. How do we get people there? And erectile dysfunction is a huge problem. You published this paper that looked at the effect of aerobic exercise on erectile dysfunction.
Right.
Without medication.
Right. Yes. Realize that healthier people tend to be more sexually active. And this study shows that lifestyle modification, diet, exercise alone, can significantly reverse erectile dysfunction. Reverse. Right? And so that's really important.
Amazing.
That's really important because most people say, just give me the pill. I say, fine, I can give you the pill, but let me tell you something that you can do to actually truly reverse your erectile function. See, remember that ED is a progressive disease. So what happens, if I give a man Viagra today, it works fine, but eventually it's going to stop working. And that patient will then go on to an injectable for penile injections. Eventually that stops working, and then they go on to maybe a penile prosthesis. So there's a spectrum here, right?
How common is that?
So ED affects 52% of men over the age of 40. It's very common. And I think another way to look at this is 40% of men at 40 have erectile dysfunction, 50% at 50, 60 at 60. You live long enough, you're going to get erectile dysfunction. And so, but it's reversible. ED is reversible, and typically with lifestyle modification. If you improve your lifestyle, it significantly improves your erectile function. Most men say, just give me the pill. I say, fine, I'll give you the pill, but you understand that that pill is going to eventually stop working, and we'll have to go to a stronger pill, and then we have to go to a penile implant. And so if you work with me, we can prevent ED from occurring. Remember that ED is the first sign of a heart attack or stroke. That is really important, right? So if a man gets ED today, 15% of them will have a cardiovascular event within 7 years. That is really important. It's not just about sex.
Those are big. Say that again. Those are big numbers.
This is prostate cancer prevention trial. If a man develops ED today, 15% of them will have a cardiovascular event within 7 years. That's important because ED is the first sign of a heart attack. And there's a mechanism. How can I explain this? The penile arteries are 1 to 2 millimeters. They're very tiny. The coronary arteries are 3 to 4 millimeters. The carotid artery can be 6 millimeters. So remember from physiology, if you get occlusion 50% of an artery, you start seeing end organ damage. So what are you going to occlude first? You occlude the penile artery first, then you occlude the coronary artery, then you occlude the carotid. So ED typically is the first sign that something else is going to happen, right? So that's very important to realize that. So we take ED as a first sign of a cardiovascular event. If a man comes to me and he has ED and 2 cardiovascular risk factors, we send them for a cardiovascular evaluation just to make sure there's not occult cardiovascular disease. And I think that's really important that men out there, particularly young men, if you have ED and there's no other cause, should be thinking, is there something going on with my heart that could be causing this condition?
Do you typically screen, when we think about the blood panels, I know that you get estradiol, testosterone, free testosterone, SHBG, hemoglobin, hematocrit, PSA. I'm assuming you still get a PSA. Do you also look at, say, ApoB?
Absolutely. So ApoB is much better than all the other ones, right? So ApoB, LP little a, and LP little a is a non-modifiable risk factor. It is what it is, but ApoB can be modified. Typically, I like to keep the ApoB below 100. You can say 130 or 100, but these are great gauges to let you know what is going to happen in terms of a cardiovascular risk. So I like the way you're going with this because I think it's very important to realize that the first sign of a heart attack in men could be his erectile dysfunction. And that's been shown, as I mentioned earlier, 15% will have a heart attack or stroke within 7 years. If a man presents to you with ED and he appears relatively healthy, if it's not psychogenic, you should ask yourself, is this the first sign of cardiovascular disease? And we take it very, very seriously.
Also, there's a whole push for these weight loss drugs. Do you also look at glucose, insulin, hemoglobin A1C? Because what I love about the way you practice and the way you think is it is not just unidimensional.
Yeah.
We're talking about erectile dysfunction, but you have your 4 pillars. You are discussing things on a broader scale and really more holistic.
Right.
The impact of these weight loss drugs, Ozempic, semaglutide, tirzepatide, what are your thoughts on them and how could those affect infertility, sexual function?
So we're studying those right now, and I think it can have a positive effect. So remember, what does fat do? Fat contains something called aromatase. It eats up the testosterone and converts it into estrogen. So the more fat cells you have, the less testosterone you have, the more estrogen you have. So basically, we like to look at these levels. Losing weight, I believe, will help with fertility. I think it will make a big difference. I think losing weight will help with sexual function. And so we have a trial right now looking at that, giving these medications like semaglutide to reduce the fat to see if I see improvements in fertility and sexual function. I think it's going to make a difference. Let's be honest. Health, it's survival of the fittest. Darwinism. Healthier people tend to be more fertile, right? So healthier people tend to be more fertile. I want you to think of this in 2 ways. There's 2 ways to play this. There's offense and defense, right?
Love it.
Offense and defense. And when you talk about offense, I say, okay, I'm going to focus on the 4 pillars: diet, exercise, sleep, and stress reduction. I'm going to do things to improve my body. But defense is looking at what we call the 4 henchmen. I got this from Peter Attia. Looking at if something bad's going to happen, it's either going to be cardiovascular disease, it's going to be either diabetes metabolic syndrome, it could be a cancer, right? Or it could be neurodegenerative, right? Those are the other ways that can get you. So we do something very silly. We wait till we get the problem, and then we treat it.
I know.
I say, I have a heart attack, and now I'm going to go ahead and figure out how I'm going to improve my cardiovascular health, right? I'm going to wait till I get diabetes, and then I'm going to try to improve my diabetes. No, the name of the game is prevention. So prevention on the over here on these, and then also on this side, trying to go offense and defense at the same time. Very important. And so we go hard on the patients. We look at cardiovascular risk. We look at ApoB. We look at LP little a. We look at their cholesterol levels. I look at ApoE for neurodegenerative, so you can look at
Wonderful.
that as well, right? You can look at insulin levels in these patients. So we go very hard on cancer screens as well. I like using the Grail as well. It helps me understand what else this patient could have.
Yeah, we had lunch the other day. My husband was there. It was great. We were talking about what you were doing in your practice. You mentioned the Grail,
Yeah.
which is fantastic, and also scans. whether it was a Pernova scan or CT.
Yeah.
You are the first urologist that I've ever heard doing this.
I think it's important, right? Because the name of the game is prevention, right? If I can catch something today, why wouldn't I? I would only do what I do for myself. So a scan, so you can get an MRI full body scan, although it's sometimes hard to get. You can get a CAT scan, but some type of imaging. Again, this is not standard of care. It's something that I think I offer my patients. It's progressive,
and it's, as you say, offense.
It's offense, right? I want to know what's going on before it happens, right? And I think that that's very important. So we use the Grail as well. I think it's very helpful to tell it's 50 cancers that you may be missing that you can't pick up today. So these are all things I can do to for cancer prevention, right? So focusing on the cancer, the cardiovascular, the metabolic, the neurodegenerative, those are the 4 categories. Because again, if you are going to die, those are the 4 ways that can get you besides having a car wreck or a plane crash. But these are the 4. If you know that, you would go heavy on those 4 and preventing those 4 from happening, right? And that to me is more the defense. Prevent, find a way to prevent. The offense is diet, exercise, sleep, and stress reduction. And when you put it together, you got a great program. You know,
you have a winning team. What effect do you think that these drugs, back to the weight management drugs, have on sperm quality? Do you think that there's any indirect or direct effect on sperm quality?
Well, we know some basics. We know that patients who are healthier have better sperm quality. That's right, survival of the fittest, Darwinism, right? Healthier patients, healthier people tend to have better sperm quality. So I would assume, and we're doing the trial now, that patients who lose weight would potentially have better sperm quality. And that's what we're studying right now. So we're looking at semen analyses in these patients, and we're looking at testosterone levels in these patients and hormone levels in these patients to make sure that we see an improvement over time. Healthier people tend to be more fertile. That's just the way it is.
Is infertility a big thing that you're seeing?
So 15% of couples will have infertility. It's a lot. We don't talk about it. 15%, and the majority of the time, 50% of the time, it's a female factor. That's true.
What percent of the time?
50% of the time.
50%.
It's a female factor. 30% of the time, it's a male factor, and then 20% of the time, it's both male and female. So indirectly, the male is involved 50% of the time when they present for infertility. But if you think about it, 1 out of 7 or 1 out of 8 couples will have problems with infertility. That's a lot of people.
It's a lot.
It's a lot of people.
And
right?
It's emotionally really, really devastating for people.
Absolutely.
What would you say if you were trying to preserve or increase fertility for men?
Most important is lifestyle modification. Healthier men are more fertile, period. Right? So if you want to improve your fertility, lose weight, exercise, alcohol consumption. So remember that alcohol can actually cause damage to the testicles as well. And typically when it's about 40 grams of alcohol.
I was going to ask you the dose.
Yeah, 40 grams. So each drink that you take in alcohol is about 14 grams, roughly. So that second drink, probably okay. That third drink is where you cross, right? So you want to watch the alcohol, marijuana consumption. So healthier people tend to be more fertile. And so I tell men, you want to become fertile? Exercise, lose weight, right? Less processed foods are very important as well, right? Sleep. Remember that men only make their testosterone when they sleep. You don't sleep, you don't make your testosterone. And endogenous testosterone is very important for sperm production. Let me repeat that. So endogenous testosterone, very important for sperm production. Exogenous testosterone makes you infertile. Right, but endogenous.
But reversible.
Yeah, but reversible can take some time.
Yeah.
On average, our studies showed anywhere from 3 to 7 months.
Yep.
Well, we could do it 3 to 7 months, but there's no guarantee that I can get you back to baseline. Right. So I started out with 80 million sperm per milliliter. I took testosterone. I went down to 0, and now I'm back to 30 million. Okay, I have 30 million per ml, but I'm not as fertile as I used to be, but I am fertile. Right. So just be very careful on the definition.
And for men, women go through menopause and then that's it. They can't have a child. But for men, can they always produce sperm? Do they always produce sperm?
Sperm production goes down as men age. And we see that typically between 40 to 45 years of age, you'll start seeing a precipitous drop. So it does go down. So it's not that you can always. Now, there's other ways to get the sperm. I can always do a biopsy of the testicle and get the sperm if I need to, if he's not producing. Male fertility is pretty easy. It's only 2 things I got to figure out. It's either they're blocked or they're not making it. There's only 2 options when I see these patients. They're blocked or not making it. And so if they're blocked, I can unblock them. If they had a vasectomy, I can unblock the vasectomy, right? If they're not making it, it's a little trickier. So you have to figure out why they're not making it, what you can do to help them. And many times you have to go in and do a biopsy of the testicle, find the sperm. I don't need very many. I just need several. Need
one good one.
One good one. And but again, I tell the patients, healthier people are more fertile. I need you to focus on your quality and health. Very important.
And what about for women? I think you focus primarily on men in your clinic when it comes to fertility. Do you work with women at all?
I work with women in the sense that I work with all the IVF centers here in Houston. And so when the couple are trying to conceive, they'll send me the male patient and say, hey, we have an issue. We can't find the sperm, or he has no sperm on his ejaculate. Can you help us retrieve it? In that sense is where I work with the women for fertility. Do I work with women for female sexual dysfunction?
All the time.
All the time.
All the time.
But for fertility, my main focus is improving the quality of the sperm and finding the sperm in these men.
Circling back to women and sexual function, you had mentioned that their SHBG goes up, and both men and women, right? A male will and can always make testosterone, and he can, for example, my dad's 74. He cringes every time I say it. Maybe he's 73. We got his blood work done. His total testosterone was 800.
Yeah.
His free testosterone was amazing, and he, again, he's an older gentleman who does all of the offensive pillars that you talk about. For women and testosterone production, does that always decline?
Yeah. So you bring up two important points. The first one is that we were taught in residency in medical school of this concept called male menopause.
Andropause doesn't exist.
It doesn't exist.
I know. It does not exist.
It doesn't exist because what happens is as men get older, aging alone doesn't drop their testosterone level. It's the acquisition of comorbid conditions that drops their level. So obesity, fat cells eat up testosterone, convert them to estrogen, called aromatization, right? HIV, AIDS, hypertension, all these conditions that you can acquire start dropping your T levels. But if you look at healthy 80-year-old men, they have normal testosterone levels.
Right.
It's still in the normal range, right? So healthy men will maintain their testosterone. But women are a little bit different. So women will typically make 50% of their testosterone from their ovaries, 50% from their adrenals. And as she goes through menopause, it's a precipitous drop in her testosterone, and her adrenals are starting to decline every year at 20 years of age. So it absolutely makes sense that her desire for sex goes down, because the number one driver for sex in a woman is her testosterone level. And at 55 years old, when she's postmenopausal, there's almost no testosterone. So you can't blame her for having low desire. Secondly, she has vaginal atrophy. She has pain. So now she has no desire and she has pain with intercourse, and you want her to have sex all the time.
She's out. Bye, Felicia.
Right. So come on. Right? It's not fair. So if you improve the testosterone level, if you use local vaginal estrogen therapy, if you help her, then it makes sense. But to assume that a woman postmenopausal is going to want to have a great libido doesn't make a lot of sense.
Yeah. This episode is brought to you by First Form. First Form makes incredible protein powders. That's probably one of my most common questions that I get asked. What kind of protein do you use? And First Form makes great flavors. They also have a natural whey, which is amazing. We make pudding out of it. We also make somewhat of like a ice cream type shake. And if you are looking for protein powder on the go, then look no further. First Form makes a great one. You can check out their protein powders, which, by the way, also mixes amazing. Nobody likes that chalky tasting protein powder where you're like drinking it, kind of choking, not sure if you should spit it out, or maybe it doesn't taste good and there's an aftertaste. It's a whole situation. First Form has fixed that. You can try yours. Go to First Form, that's 1stphorm.com, and use the code Dr. Lyon. That's firstform.com/Dr. Lyon. We talked about testosterone, we talked about Addy, and there was another one.
It's bremelanotide, or Vyleesi.
Okay.
So this is FDA approved also to significantly improve desire for sex in women. So we have two drugs on the market. One is called Addy, one is called Vyleesi. Addy is an oral pill that she takes every day. Vyleesi is an injection that she takes typically several hours before sex. Now, Vyleesi should be taken no more than 8 times a month, and but she doesn't have to take it every day. Both have different mechanisms of action, but both significantly increase the desire for sex in women.
Gosh, I mean, it just seems like a combination of one or two of these things would be amazing for women and not have to suffer.
Yes.
The testosterone for women, you'd mentioned that women after menopause, I know that there's some concern. I'm not sure how valid it is after a 10-year window, not wanting to put people on estrogens. What about testosterone?
Yeah, so there's been no data to suggest that testosterone increases any kind of cancers or malignancies in women. So the fear that we have with estrogen and progesterone is that we can get ovarian cancer and we can get other kinds of cancers, but that's not been shown with testosterone. And testosterone has been used for decades in women with no really adverse events. Remember, the concept of testosterone and these hormone replacement is to put the woman who is low back into the normal range. It's not rocket science. We're just going from low back into normal. And the effects that I see in women on testosterone tend to be greater than we see in men. I mean, the libido goes up, her energy goes up, her muscle mass goes up, cognition goes up. Again, realize that it's off-label in the United States. So many years ago, they would try to get it through with a drug called Intrinsa. It is used throughout the world and on-label in different countries, but it's off-label. So what you use in a woman is 1/10 what you use in a man. That conversion is very important. And go slow. You don't want the acne or the facial hair because you can get very upset. So it's very, very slow.
Very slow.
But it is effective. And let's talk about other benefits. Bone mineral density.
Yes.
I mean, we talk about estrogens for women for bone mineral, but testosterone, there are many studies showing that the combination of testosterone and estrogen for bone mineral density is better than just estrogen alone, improving her bone mineral density, her cognition, her skin. I mean, we can go on. And it's just very unfortunate that it's not FDA approved for women now. But you can use it off-label.
You can use it off-label.
But just go slow. Just remember 1/10 the dose is how you want to remember it.
That makes sense.
Yeah.
The blood work that you do, and we talked a lot about sex hormone binding globulin, and that testosterone for men, the production doesn't have to decline precipitously, doesn't have to be drastic, but sex hormone binding globulin goes up as individuals age. What can we do about that, if anything? I have tried certain supplements. It doesn't really move the needle. The question is, if we give boron or if we give X, Y, and Z, does it actually have a meaningful impact? I haven't found it to.
Yeah. The best way to solve the problem is if your SHBG is fixed, just raise the total T.
Yeah.
It's a math formula, right? So essentially, if you want to have a higher free testosterone, raise the total T above what you need to have a higher free T, and it works. There are things that can lower the SHBG, but the benefit with the amount of work you have to do is not worth it. Just raise the total T, and you'll get there.
It seems like a very straightforward, easy answer, but people still really, really struggle.
Yeah, but don't get fixated on the SHBG.
The numbers.
How does she feel? How does he feel? That's the most important part. Everyone's like, well, my number is not high enough, so I must not feel good, so therefore I don't feel good. That's why I never let them know their value first. I say, how do you feel? Right? If they say I feel better, it's basically every person has their own cut point. We all do. And I just have to get above your cut point to get you to feel better.
And that's all doable. I know that I want to honor your time, so I know that we're running out of time. But are there certain common misconceptions that you would love to clear up, whether it's through sexual health, just anything in your domain that really needs to be stated? We talked about prostate cancer, we talked about cardiovascular disease, we talked about propecia, finasteride. These are all so meaningful.
Yeah.
Are there any misconceptions?
There's several. So first of all, we know now that testosterone does not cause prostate cancer, right? For decades, we were taught that testosterone causes prostate cancer. That's been put to rest. Now we know that testosterone does not increase the risk of a heart attack. With the Traverse trial, finally, people say, if I take testosterone, I'm going to get a heart attack. So that's been a misconception. Those are two big things that I think people should know. I think that people should also know that ED is the first sign of a heart attack. Right?
Huge.
That's really important.
Huge.
If you look at that, there's something called the arterial diameter theory, as I mentioned earlier. You will occlude the smallest arteries first, right? And so ED will precede cardiovascular disease in many cases. And so if a young man presents to you with ED and no other risk factors, I get concerned that I may have occult cardiovascular disease. And if they have two risk factors, I will send them for cardiac evaluation. So just be cognizant that ED could be the first sign of a further problem, particularly cardiovascular. That's a really important point.
And you even mentioned about infertility and alcohol. I think people fail to recognize that. And then the impact of marijuana or other drugs.
Yeah, they can. So people use these recreationally, but they don't realize that they can have a significant impact. I've never seen a great study to say how much marijuana do you have to smoke to have damage to the testicles. We do know that in alcohol studies, it's typically 40 grams, right? So that tells you if I have more than 3 drinks, I'm going to start causing damage to my testicles, meaning that I can impair not only my sperm production, but my testosterone production as well, right? So just careful, in moderation if you're going to drink. But, you know, these are all what we call gonadotoxins. Just be very cognizant of the things that can cause damage to the testicular tissue.
What are you working on now? Let me rephrase that. What are you not working on? I'm kidding. But you are very prolific when it comes to publishing and exploring questions that are going to have a meaningful impact. What's on the horizon?
So we have a lot. You know, I have a basic science lab, and in the lab, I have some amazing people in the lab looking at something called the CAG repeat. So we're looking at something called the sensitivity of the androgen receptor. And we talked about this earlier. We found that those patients who come in and I raise their testosterone to 800 and they say, doctor, I still have symptoms. Maybe there's something genetic going on, why they still have symptoms. And if you check the CAG repeat, if it's long, 27, 28, it explains that these patients may need more testosterone to get symptomatic improvement. So we're looking very, very closely at that. We're still looking at shockwave therapy. I think that, you know, we didn't talk about treatments for ED, but some of the cool things.
We should. Let's talk about it. If you have time, I want to talk about these treatments.
So my favorite way to treat ED is lifestyle modifications. Let's be clear.
Okay.
If I say, look, don't go for the pill. Go for the diet, exercise, sleep, and stress reduction.
How fast will you see a change, you think, from erectile?
It depends on how quickly someone is willing to put in the lifestyle modification changes, right? But we can see them over the course of 6 to 12 months if patients want to commit. There was a wonderful story by Esposito. She did a wonderful study, randomized controlled trial, 2 years, lifestyle modification or no lifestyle modification in 110 obese men, 55 in each arm. She followed them for 2 years. This was in JAMA. And with lifestyle modification and weight loss, they saw a significant increase in erectile function without pills. I mean, this is just without pills. So I say, look, the best way to do this is to lifestyle modification, because it's not just your erections. Your overall health is going to improve. Unfortunately, most men say, just give me the pill. Right? I say, fine. Right? But lifestyle modification makes a big difference. So, but you know, the key is here that if you can do the lifestyle modification, most patients, if they stick with it, I see numerous other benefits as well.
And then the shockwave therapy, does that work?
Shockwave therapy is
booming.
And
what is that?
So essentially, when I first saw this came out in 2010 by a gentleman named Dr. Vardy in Europe. And what he was doing was he was taking a device, it's a shockwave device, essentially, and shocking the penis. It's basically like a pulse, electrical pulse. What he showed was in those patients that got shockwave, they were seeing improvements in erectile function. Now, I'll be honest with you, when I first saw this, I thought it was ridiculous. It made no sense to me. But it's actually brilliant, because what you're doing is you're tricking the body and you're inducing a trauma state. And when the body sees trauma, the body is an unbelievable healer. So you're telling the body, I have trauma in the penis. And what he showed in that study was that those patients who did the shockwave saw a significant improvement in erectile function. Since then, there's been a boom in the United States. Everywhere you look, there's shockwave devices.
And for women, too.
They have been also for women, for sexual dysfunction, for many causes. But for sexual dysfunction, and it makes sense. This actually came out in the cardiac literature before it came out in the urologic literature.
Oh,
and
that's
they still do it,
interesting.
where they'll use shockwave on the heart, induce trauma, and you get neoangiogenesis in blood vessels within the coronaries. So we use it now for ED, but you have to be careful. There's different classes of drugs. There's class 1, some class 3. Class 1 do nothing. They're pneumatic. They don't do anything, but they make a click. And so patients hear it, and it's a big business. It's anywhere from $500 to $1,000 a treatment. And if you buy a class 1 drug, anyone can buy a machine, anyone can buy it.
Okay.
And so you have to be careful, because they don't really do anything at all. And if you treat someone for 6 treatments and they pay $6,000,
that's very expensive.
It's very expensive. There's a placebo effect.
Is it 30%?
30 to 40%.
Is it really?
How'd you know that?
What do you mean?
Yeah, it's 30 to 40%
yeah.
with this thing. So,
Yes.
So 30 to 40% of patients who get the class 1 machine will say, I got the best erections I've ever had in my life. It's a placebo effect, right? But the class 3 ones are regulated. And those machines have been shown to have efficacy in improving sexual function. So using the right type of machine, these are called electromagnetic, electrohydraulic, they're very good machines. And remember that not everyone sees improvement. So remember that, you know, a lot of patients will. I think mild to moderate see the most improvement, but not everyone will, because ED is multifactorial. There could be a psychogenic cause. There could be a lot of other factors going on as well. But right now, those are not covered by insurance, so it's a cash business.
Do you think they're effective?
I do think they're effective if you're using the right machine and the right patient, right?
Okay.
The right machine and the right patient. If you're using a class, the electrohydraulic, electromagnetic, if you have patients with mild or moderate ED, they don't have significant fibrosis and scarring, then you have a better shot.
But would it be, it's not necessarily correcting the underlying cause? I mean, again, it's multifactorial.
It's
like
multifactorial, but
yeah.
it's improving the quality of the tissue, and that's really important because you're bringing in new blood vessels into that penile tissue. You're improving the quality. So basically, the body is one of the best healers. If I cause any trauma to your body can heal it. It's pretty clever, except when it's gone to the state of fibrosis. If the penile tissue is completely fibrotic, I can't get you from scar back to normal tissue.
Right.
But if they're not fibrotic, you can actually reverse the ED process by using these. Now, there's stem cells that are out there. We had the first stem cell trial in the United States for ED using this trial was, though, using a FDA-approved machine. And we did find that there was some benefit in ED, but it wasn't sustained. It was only about 6 months. So, unfortunately, there's not a randomized placebo-controlled study with stem cells for ED yet.
Yeah.
And that's sad because that's an easy study, right? But there's not a randomized placebo. There's a lot of randomized placebo-controlled trials for shockwave showing benefit. And the last one is PRP. So platelets is the third realm. There have been a few studies suggesting that may be beneficial. A recent one out of the University of Miami showing no benefit at all. So again, be careful because a lot of these treatments are cash, and you just have to be very careful because this is a very vulnerable population,
Yeah.
and they're willing to pay the money. So you just got to be careful.
And I just thought about this as you were talking. Does the penile tissue atrophy?
It does with non-use, for sure, like any muscle. And so where do you see the most atrophy in men? Typically around 52 years of age. Why 52? That's an odd number. It's because that's when women go through menopause, right? So as she goes through menopause and they stop engaging in sexual activity, he will see more and more atrophy of the penile tissue. He'll develop something called venous leak. So now the blood will come out faster than it goes in. And so once you get venous leak, then it's harder to get an erection. So really important to keep the penile tissue healthy as we get older.
Do you think educating on this, if you were to wave a magic wand, do you feel like your contribution would be to educate on this much earlier?
Absolutely, because as you stop using the penile tissue, you can start developing fibrosis and scarring, which I cannot reverse, right? So you want to keep the tissue as healthy as long as possible. Maybe you're not having sex today. Maybe you're not. But maybe you will want to have sex in 5 years. And if you don't keep the penile tissue healthy today, you won't be able to have sex in 5 years. So it's really important to keep the tissue healthy.
Yes. Well, that gave listeners a free pass to have lots of sex, and they are very excited and hopefully have a great and willing partner. Dr. Mohit Khera, thank you so much. I encourage everybody listening to follow you. I will include all of the links. You are doing extraordinary work. The world is so lucky to have you.
Oh, you're too kind. Thank you.